now it's my pleasure and honor to invite Dr. Patrick Serruys. When we were students, he was already a role model for us. So then it was always our wish to have him. Sometime back, we had performed a case cath lab. He may not remember, he must have done in many. We have present remembrances of it. And then he gave a multi-vessel PCI. He brought it into interventional cardiologist era by syntax trial and making it where at least 2/3 of those cases could be effectively tackled by PCI also, especially with availability of better quality regulating stents. And then with the BVS era came OCT imaging, all that was made popular by him, though that Babbitt is working on other advances. But now I was surprised when he suggested me this talk. That is the beauty of cardiology, I would say. You can select your specialty as per your choice, and all of them are important in cardiology. Now he's about to talk to us on CT coronary angiogram. Will it replace invasive angiogram in the future? Always they used to doubt. I always believe that what is good for the patients will have to work in the long run. And people were worried that the angiograms would decrease with CTA coming. But sometimes it would also be the other way. Patients come with some CT angiograms where some lesion is picked up, which otherwise would have not been done. Now go for angiogram. So finally, it balances out. We always need to look at what is important for the patient and do what is right for the patient. I think let us hear thoughts of Dr. Patrick Serruys on this aspect of CT angio. Over to you, sir.
Thank you very much. It's a nice, kind words, and indeed you have introduced the debate very well. It's a pleasure to be in India today, at least virtually. Let me start by what I call the chest pain pathway today, which is invasive coronary angiography and ad hoc intervention. When you got a patient with new onset of chest pain, you have the case history, the risk profile, but what's very important is the ECG at rest. And if you see an ST elevation, you rush in the cath lab, and that's the world of emergency care. But if the ECG is non-significant and the troponin is negative, then you got in the world of non-invasive tests, chest X-ray, echocardiogram, stress ECG, dobutamine, echo, MRI, CTA, adenosine SPECT, PET, Holter tape, starting pharmacological treatment, waiting, postponing the decision to move to coronary angiography. And then if you have finally an equivocal diagnosis of prognostic concern, of refractory angina with incomplete remission, then you cross the line of invasiveness to the cath lab. And you have to cross a second time the line of invasiveness if you want to do an ad hoc intervention. But Manesh Patel told us many times that about 2/3 of the patient have what we describe as a non-obstructive disease, and that's bad news because you cannot help this patient with surgery of PCI. Now, the future vision is a cardiac CT as a one-stop shop that increase the quality and the effectiveness of medicine. And in this patient with ECG non-diagnostic troponin normal or abnormal, you could have the cardiac as a one-stop shop. Angiography for the stenosis detection, fractional flow reserve for the epicardial conductance, perfusion with hyperemia, microcirculation, plaque anatomy, inflammation, inflamed fat perivascular, ejection fraction, wall motion analysis, valve morphology, Lehman's curve, syntax score, calcification map, and you have only one line of invasiveness to be crossed for therapy, either the cath lab with a carefully planned coronary intervention based on pre-existing information, that's the interventional suite, it's no longer the cath lab, or a bypass surgery. So let's say a word about the anatomical approach, the substitute for cine angiography. First, this table showing that CTA in patient with suspect but unknown CAD has an excellent sensitivity around 85% and 100%. and a pretty good specificity between 64 and 98%. Now, one word about the physiology, the CTA as a substitute for intracoronary pressure wire recording. This next video is a crash course in physiology derived from multi-slide CT scan. You see the original multi-slide CT scan, the lumen center line assessment, removal of plaque based on ounce fill unit, lumen surface determination, myocardial mass assessment, finite element analysis, computational fluid dynamics based on Navier-Stokes equation, to end up with the drop in intracoronary pressure and concomitant reduction of flow across the lesion with an FFR of 0.98 in the proximal LAD and an FFR of 0.60 distal to the stenosis. In the mid part of the LAD, the FFR change are color-coded with the worst value in red. Now, in this recent meta-analysis of FFR-CT versus CTA, we can appreciate the superiority of the FFR-CT with respect to the CTA at the patient level and at the vessel level, with an area under the curve of 0.90 and 0.91. Now, from the National Institute for Health and Care Excellence in UK, the first line of test has been proposed at CTA with FFR-CT that may lead to cost saving, at least that was their calculation of 240 pounds per patient, with potentially an increase of CTA by 400% and a reduction of invasive angiography by 60%. And there was immediately a debate in the European Society of Cardiology with this paper, should NICE guideline be universally accepted? And the final conclusion was in favor of CTA, provide FFR-CT and iris plaque are properly evaluated. Finally, in the ESC guideline of 2019, coronary CTA with non-invasive functional imaging became a class 1 level B. And the NICE report in January this year has led to a calculation and a demonstration of cost saving, not of 214 pounds per patient, but 357 pounds per patient. At one point, we became convinced and confident about the capacity of CTA in helping a heart team in decision-making between surgery and PCI in multivessel disease. And that's the syntax tree revolution published in the European Heart Journal. In this trial, we randomized for the first patient the doctors and not the patient. And the trial was virtual. Let me explain. In patient with left main and three-vessel disease on conventional cine angiography, a CTA was performed and a single patient was randomized between two heart teams. One heart team has only access to the cine angiography and the other had access to the computed tomography angiography. And then each heart team has to make a decision on the treatment based on the syntax score 2 described in the Lancet 2013 as a combination of anatomic syntax score and comorbidities. And the primary endpoint was the concordance of the two decision-making by each heart team at the time of the investigation was evaluated by kappa statistic. We were expecting a kappa above 62. We found a kappa statistic current test of 8.82, an almost perfect concordance in the kappa statistic, with an agreement between the two heart team of 92.8%. The secondary endpoint was the FFRCT in the decision making, the impact of the FFRCT in the decision making. And we'll discuss later on what is the additional value of the FFRCT in decision making. So this is the typical session that we had on Wednesday, starting by the 3D maximum intensity projection. You could see that this LAD is disease on a very long segment, at least up to the second diagonal. Then there is a lot of calcification in the LAD. There is, as you would see, a very short main stem, and then a bifurcation of the main stem between the circumflex and the posterolateral. If you look at the right coronary artery, there is some narrowing that in the first bend. And then there is, if you look carefully, a small nodule of calcium just at the ostium of the right coronary artery. And again, you see the disease segment of the LAD. And by the way, look at the calcium in the aorta. The surgeon will have to be prudent if you want to cannulate this aorta. After the MIP, we used the multi-planar projection. You see the right coronary artery. The ostium is indeed very suspect. There is a lesion here. We give a 3-point and 1 point for the additional narrowing. This is the LAD, and you recognize this quite long segment, which is disease. Distally is pretty fine, but that segment is disease. It is the segment 7. It deserves 5 points with an additional point because it's a long segment of 20 millimeter. No doubt about the circumflex and these complex bifurcation called Medina 111. That gives you 1.8 point. So altogether, the multi-slide derived syntax score was 24 point. Now we get the functional information. First, let's start by the right coronary artery. I was somewhat surprised to see that it was not an ostium lesion. There is a small gradient, there is calcium, but as you could see just before the bifurcation, the FFRCT is still 0.85. LAD, no problem between the first and the second diagonal. We got an FFRCT clearly below 0.8. And the story of the bifurcation, the circumflex, is very clear. You will have to treat these 3 vessels. So if you take the functional CT syntax score and you put that in combination with age, creatinine clearance, ejection fraction, left main, gender, COPD, and peripheral vascular disease, you come to syntax score 2, which are quite comparable, and the 4 years mortality predicted is not too different. So you have basically what we call equipoise between CABG and PCI, and we went to PCI in that case. What about the angiogram now? Because that's the other heart team who has access. Yes, there is maybe something at the ostium of the right, but look at the backflow during the injection of the contrast. That's not the catheter wedging in the ostium of the right, and you can negate that lesion. Nevertheless, it was described a lesion in the first bend with give 2 point. This is the LAD selective injection in the circ, but you can recognize that pretty long segment here in the LAD after the second diagonal. And that gives you 7 point in the syntax score. And then the selective injection in the circ, no doubt, a very complex Medina 111 bifurcation. So we have a 20 point, this time not by the multi-slide CT scan, by the conventional angiography. And again, you make your calculation, you get to very similar result, and you conclude equipoise. It doesn't matter if it was defined by the multi-slide CT scan or the cine angiography, both decision-making were equivalent. You have seen this result. Now, one word about the value of the FFRCT in addition to the anatomy. This is the main illustration of circulation cardiovascular intervention. We conclude that there was the FFRCT changed the treatment recommendation between PCI and CABG in 7% of the patient. The FFRCT changed the vessel to be revascularization in 12% of the patient, and the FFRCT reduced the number of patients with real three vessel disease from 92% to 79%, a decrease of 13%. Now, the real things has started. This is the BMG paper describing the protocol safety and feasibility evaluation of planning and execution of surgical revascularization solely based on coronary CT and FFRCT in patients with complex coronary artery disease study protocol of the fast track study. And you see the real thing has started. We have enrolled already 1/3 of the total population, 33 patients. You got the CTA with heart flow. It is transferred electronically to the academic call-up in Galway. And then we describe the anatomy. We got also the FFRCT. And then we provide this information to the surgeon. And then the surgeon has the capability, the choice to say, no, I don't believe in the multi-slide CT scan. I want to see the real thing. I want to see the conventional cine angiography. But surprise of surprise, we knew that all the case so far has been accepted by the surgeon without looking or without asking a coronary angiography. And then, of course, we have classically with the feasibility, the safety aspect, and we are repeating the coronary angiography at the multi-slide CT scan at 30 days. We'll go quickly because you have got the message. This is again a 3D maximum intensity projection. You have here a very complex LED lesion with, as a matter of fact, a total occlusion and a bridging collateral. You have, as you could see, in the multiplanar, 3 lesions in the coronary, the right coronary artery, not too severe, with not too much calcium, but clearly the LED is very diseased. And at this side, you just have a total occlusion with just bridging. And you could see also the main stem with this trifurcation between the circumflex, the obtuse marginal intermediate, and the LED. So on top of that, as usual, we provide the surgeon with the functional assessment. They decide to bypass the right because just at the site of the bifurcation, the FFRCT was below 0.8. The LED was absolutely no issue, has to receive a bypass as well as the obtuse marginal. And this was the plan made by the team of the CTA planning and operating our team. They intend to put an LED of the Lima, a saphenous vein graft on the diagonal, and a saphenous vein graft on the obtuse marginal. And as a matter of fact, the actual treatment was even better because there was a Lima on the LED, a saphenous vein graft on the diagonal number 1, and a Lima on obtuse marginal. This is the safety assessment 30 days later. Beautiful work of the surgeon with a Lima, the saphenous vein graft, and the Lima. Everybody is happy. So this is my last slide before the conclusion. That's what I call the pyramid of coronary artery disease. I didn't have the time today to show you that the multi-slide CT scan is a wonderful instrument to rule out CAD. Then you have this terrible disease, and we have been already talking about the so-called non-obstructive coronary artery disease, which could be a major plaque burden diffuse, nevertheless still with an FFR borderline. And we are engaged in a trial with inclisiran, where we work giving 2 times a year inclisiran, the inhibitor of the PCSK9 through the microRNA. That's our target here in yellow. But what we are testing now, what I show you tonight, is the fact that we ask the surgeon to operate the most complex patient with 3-vessel disease and left main. And if the fast track trial, CABG, proved the feasibility and safety of non-invasive imaging guidance for CABG, and we are on the right path with 33 patients, then the surgeon in the future can, and will operate safely the most complex patient of the CAD Pyramid with the sole guidance of CTA and FFRCT. And then the interventional cardiologist should not have any reluctance in intervening on patient whose he knows in advance the anatomy, the functionality, and the tissue composition of the stenotic lesion. I didn't have the time to show you that. Even before entering what we used to call the catheterization laboratory, now upgrade into an interventional suite. So I try to convince that non-invasive coronary imaging by multi-slide CT scan with functional assessment by FFRCT could become a cost-effective first line of diagnosis. The adjunction of physiological epicardial conductance and myocardial resistance further boost the diagnostic capacity of the technique. Decision-making between pharmacological treatment, PCI, and CABG based solely on non-invasive imaging becomes a reality in this decade. And finally, as emphasized by the previous speaker, non-obstructive CAD, which has these 2 components, the epicardial vessel with plaque burden barely encroaching the lumen, which is a dangerous disease, and its microcirculation component with vasospasm. And that can be diagnosed by non-invasive imaging and become a privileged target for primary prevention based on lifetime modification with or without aggressive pharmacological treatment. Thank you very much.
Thank you, Dr. Patrick Serruys, for an excellent lecture, and you're visionary and you propose newer things which are likely to happen in future. Wish this can happen, but only CT when it is clubbed with, I think, FFR CT, then it could have more role, because as of now, only if you go by calcification and anatomical things, sometimes it could be leading to surprises. And as we know, lemas also get blocked, the lesion is not tight, and such problems we could face. But if it is clubbed with FFRCT, which becomes cheaper and cost effective.